Hello.
Will be
Dr. Marion. Oh, go ahead.
This will be posted to the CBT for SUD SharePoint site shortly after today's presentation. The presentation material is available from the file download window in the lower left-hand side of your screen. If you're having difficulty downloading the presentation, please indicate this in the chat and someone will assist you, or you can access the slides on the CBT-SUD SharePoint site. In order to obtain your CMEs and CEUs, the evaluation in TMS will need to be completed no later than March 17th. If you did not register in TMS, or if you experience any difficulty accessing the evaluation after today's session, please send your TMS ID to me, Ananda Fazal, at ananda.fazal.va.gov, and I'll put my email in the chat for you. And now I'm handing it off to Marianne. Marianne?
Thank you, Ananda. Can you hear me okay?
Just fine, thank you.
Okay, great. This is Dr. Marianne Nyes. I'm the program manager for the evidence-based psychotherapy training programs for substance use disorders. Welcome, everyone, and thank you for joining us. Today we have with us Dr. Andrew Saxon, Director of the Center for Excellence in Substance Abuse Treatment and Education from the VA Puget Sound Healthcare System in Seattle, Washington. Preceding his entry into psychiatry, Dr. Saxon completed an internal medicine internship and worked for 4 years as an emergency room physician. Subsequent to his general psychiatry residency at the University of Washington, Dr. Saxon had more than a quarter of a century of experience as a clinical and research addiction psychiatrist. Dr. Saxon is board certified with added qualifications in addiction psychiatry by the American Board of Psychiatry and Neurology. Dr. Saxon sits on the editorial boards of the journals Drug and Alcohol Dependence and General Hospital Psychiatry. His current research work is supported by the VA Department of Defense and the National Institute on Drug Abuse and involves pharmacotherapies and psychotherapies for alcohol, cocaine, tobacco, and opioid use disorders, as well as work in co-occurrence of substance use disorders and PTSD, and also reducing homelessness. So why don't we get started? I'd like to welcome our speaker, Dr. Andrew Saxon, to today's CBT-SUD Advanced Consultation call. Dr. Saxon?
Hello, everyone. Thank you for joining me. This is going to be a two-part presentation to help you understand how you can best use medications to help your patients that you're treating for alcohol use disorder and for opioid use disorder. The first part will be on alcohol use disorder, and then next month we'll talk about opioid use disorder. So we're going to start at the document that should be your go-to source for information that you need on how to treat substance use disorders, which is the clinical practice guideline that was put out by the VA and Department of Defense just at the very end of 2015, so slightly more than a year ago. And very conveniently, in one table in that document is listed many of the topics that we're going to be addressing today. So this table talks about treatment for alcohol use disorder. It lists at the top pharmacotherapy and at the bottom psychosocial interventions. So you can see that there are 4 first-line medications, 3 of which are the top 3, are approved by the Food and Drug Administration for the treatment of alcohol use disorder: acamprosate, disulfiram, better known by the brand name Antabuse, and Naltrexone, which comes in 2 formulations that we will discuss. The 4th medication, which is not FDA approved, is topiramate, but there's a very strong evidence base for this medication. And then there's a 5th medication, which is listed under number 6 there, gabapentin, which is a second-line medication. And then, of course, you can see the psychosocial interventions. And for this group, naturally, what we're going to be talking about today is the relationship between these medications and cognitive behavioral therapy for substance use disorders, which is a first-line behavioral intervention for alcohol use disorder. Now that you've heard about these medications, and maybe some of you know a bit about them already, we're going to have our first polling question. So which of the following medications do you preferentially recommend for your patients with alcohol use disorder? Okay, I think the numbers have pretty much stopped changing, and it looks like there's fairly good familiarity with these medications already, and I'm gratified to see that people like using Naltrexone. As you hear my presentation, you'll find that that's the way I lean as well, although we do have to individualize the medications for patients. So we're going to go to the next slide. And these are data that were collected in the VA. You'll see that the data are a decade old, but really the situation hasn't changed very much. And what you see here on the y-axis is the percent of veterans with alcohol use disorder who are receiving a medication. And on the x-axis, we're looking at the different VA facilities. And the crosses are specialty care and the dashes are no specialty care. So naturally in specialty substance use disorders treatment, there's more use of medications, but even at the very most, only about 20% of these patients are getting medications that can help them. And I think the average across the VA now, which isn't much different from this, was about 7%. Now, I realize that many people listening to this presentation are not going to be the prescribers of these medications, and so you may wonder, why do you even need to know about it? And I think there are many reasons, but two prominent ones. The first is that, of course, some of your patients that you're treating with CBT will be on the medications and may come to you with questions about them, and certainly you need to know how the medications might affect them. But I think even more importantly, because there is a low use of these medications, you can often be the individuals who, for your patients who may be not using alcohol but may be having intense cravings that are bothering them, or maybe even for your patients who are struggling with some ongoing alcohol use or major relapses, you may be the ones to recommend, please go see a prescriber and get on one of these medications, and you may be the one to help them decide which of the medications is right for them. So I think all of you are key players in the effort to get more patients treated optimally for their alcohol use disorder. And that brings us to our next polling question. And actually our final polling question for today's presentation. When combining an alcohol use disorder medication with CBT-SUD, about what % of the treatment effect is related to the medication? The numbers are still changing a bit, so I'm going to wait just one more minute. So I think most of the answers are in, and it's a bit cruel of me to make you answer a question to which there's no right answer, but I wanted to see what people thought. And we'll hear a little different story next time with opioid use disorder, but for alcohol use disorder, the kind of work that you all do, the CBT-SUD, is really the primary foundation of treatment. And medication can add a bit to that. And I think it's correct, as everyone here with the presentation day has answered the poll, it's probably somewhere between 25 and 50% of the treatment effect can be exerted by the medication, and the rest and most of the effect is going to be exerted by the work that you do. So with that as a background, we're going to jump right into talking about the medications. Disulfiram or Antabuse has been around for closing in on 60 years now and is FDA approved. And it's an interesting background story that this medication was being investigated by Danish scientists as an antibiotic to treat flatworm infection. And so there really were very few restrictions on how research was done in those days, and they found that yes, if you put disulfiram in the test tube with the flatworms, it definitely kills them, but what about in the human body, and is it even safe for humans to take it? So but because there were no restrictions, there were no institutional review boards, researchers could do whatever they wanted back in the 1930s, they sat around in their lab and they took some disulfiram themselves as their own research subjects, and hours went by and they felt fine, no side effects whatsoever. Hey, a scientific victory, let's repair to the tavern and celebrate. So they quaffed a few, and then they were retching and turning red and writhing on the floor, and a new medication for alcohol use disorder was born. What you see here is the major metabolic pathway for alcohol. Alcohol, or ethanol, undergoes a reaction that is catalyzed by the enzyme alcohol dehydrogenase, listed here as ADH, and that transforms ethanol into acetaldehyde. Acetaldehyde undergoes further transformation by a chemical reaction that is catalyzed by the enzyme aldehyde dehydrogenase and is turned into acetate, which is essentially vinegar that can be excreted by the body. What disulfiram does is it blocks this enzyme, aldehyde dehydrogenase. That leads to a buildup of acetaldehyde if disulfiram and alcohol are combined. And acetaldehyde has some mildly toxic effects that make that an unpleasant experience. That leads to the disulfiram alcohol reaction, which is typically not life-threatening but very unpleasant if it occurs in a severe way, and is kind of like an instant case of the flu. And you all can read the various symptoms that could occur, and I'm not going to read them off to you right now. So the idea would be someone agrees to take disulfiram. They know that if they consume alcohol at the same time, they might get very ill. That deters the alcohol use. Well, how well does that work? We have a study that's very relevant to us since it was done entirely in the VA, and it was a multi-site, partially blinded, controlled randomized trial. Now, the reason for typically when we like to do medication studies, we like to have full blinding, which is that neither the treatment providers and researchers nor the patient participants know whether they're getting a placebo or the active medication. But if you think about one of the ways in which disulfiram works, which is that you have to know that it's in your system so that it deters you psychologically from consuming alcohol. If you did a totally blinded study and people didn't know whether they were getting the real medication or a placebo, they would be very tempted to test that out. So it wouldn't really mimic what happened in the real world. So here's the design they used in the study and also the primary outcome. So they had three conditions. One was 250 milligrams of disulfiram, which is the active dose that's typically used, and one was just 1 milligram of disulfiram, which is a inadequate dose. But these people were told, both groups were told, you're getting disulfiram. Then there was a third control group which was told that they were not getting an active medication. Now this also shows the outcomes. So the primary outcome for this study was total abstinence over 1 year, not even a sip of alcohol passing through the patient's lips. And what you can see here is there was not any difference in the primary outcome between the three treatment conditions. The black parts of the bars indicate people who were lost to follow-up, and it's very clearly labeled the ones who were not abstinent and those who were abstinent. However, if you drill down into their data more and you look at the patient participants who were adherent to taking their medication, and you ask them, both them and their significant others, how many days out of that year did they actually consume alcohol, there's two patterns that jump out at you. First is that the participants and their significant others differed in their reporting, with the significant others always reporting more days of alcohol use no matter what the condition was. But regardless of whether you asked the participants or their significant others, those who were on the 250 milligram dose consumed alcohol on significantly fewer days than the two control groups. So it's pretty clear from the study that disulfiram can reduce the amount of alcohol used, and although when we're treating our patients, we like to go for a goal of total abstinence, any amount of alcohol reduction is going to contribute to better physical and psychiatric health. So there is definitely some positive benefit for many patients to taking disulfiram. So the dosing, as I mentioned, is typically 250 milligrams per day. It's a once-a-day medication, which makes medication adherence somewhat easier than multiple dosing. And the key point on this slide is, obviously, this is not a medication we can use for people who are actively consuming alcohol. People have to be able to put together at least a couple days of abstinence before we can start it. So that might limit its use for some of your patients. Also, there is a potential for a very rare but very serious side effect with disulfiram, which is potentially fatal liver injury. So patients on disulfiram do require, especially in the first 3 to 6 months of treatment, very careful monitoring of liver blood tests and also careful clinical monitoring to make sure they are not developing signs and symptoms of any liver injury. But as you can see, that is very rare. Now, we're going to just veer a little bit off course and talk about cocaine rather than alcohol, because there's a very interesting study that looked at disulfiram and CBT for patients who, back in the DSM-4 days, cocaine dependence, but most of these people also consumed alcohol, so it is relevant in that way. This was a somewhat complex study, although not the most complex study I'll be talking to you about today, so preserve that for later. So it was a 2-by-2 study where people either got active medication or placebo, and they also were randomly assigned either to get CBT or to get a different form of psychotherapy, interpersonal psychotherapy. And here are the results. What you're seeing is on the y-axis the number of cocaine use days per week, and on the x-axis study week as you go from left to right. And what you can see here, so the active medication disulfiram treated patients are in the black, the placebo-treated patients are in the white, and the triangles are the CBT, and the circles are the interpersonal psychotherapy. So if you got disulfiram in this study, it didn't matter which type of psychotherapy you got, you were going to do reasonably well. And if you didn't, if you got the placebo, you're going to do a lot better, although not as well as the people who got medication if you got the CBT. And of course, for all of you CBT experts out there, that makes total sense. Someone initially entering treatment for a substance use disorder needs a pretty structured psychotherapy, and they certainly have often have a lot of disruptions in their interpersonal relations, but that is not the primary issue that they have to deal with early in treatment. Maybe later in treatment it can be very important. So CBT scores a partial victory here, but does better when combined with medication. Now we're going to move on to the medication that you all endorsed as the one you think works best, which is Naltrexone, which has an active metabolite, 6-beta naltrexone. So naltrexone is a orally and parenterally, meaning it can be injected, effective mu-opioid receptor antagonist. And to help you understand its mechanism of action, we're going to do a very quick review of some neuropharmacology principles that many of you may know already, but I want to make sure we're all on the same page. So we're starting very simply with what a neuron is. And the nerve cell is made up of the body of the cell where the nucleus and the DNA is contained. It's made up of a lot of dendrites, which are the parts of the cell that receive inputs from other neurons, and then it has an axon with a terminal, and that's how the nerve cell, that's where the area where the nerve cell generates electrical impulses to communicate with other nerve cells. Having seen that in isolation, here's how two nerve cells connect. Our original nerve cell sends an impulse down its axon. That's an electrical impulse. It reaches the terminal, and the terminal comes into close proximity with the dendrite of another neuron. So that electrical impulse is going to give a message to that neuron and so on. Now we're going to look at things more microscopically. So here is the axon terminal. Let's see, I've lost my pointer here. So here is the axon terminal. Here is the dendrite of the receiving neuron. And in that space, there's what's called the synapse, which is a very small gap of salt water between the neurons. So the electrical impulse cannot jump over that synapse, and the way nerve cells get around that is they release chemical messengers or neurotransmitters that can cross that gap and go across to provide the message to the receiving neuron. So you can think of that as like a train speeding down the track, but suddenly it comes to a canal and the train can't go across the canal, so it has to get on a ferry boat that takes it across the canal to dock at the other side. Here is the synapse, even more magnified, and the neurotransmitter we're looking at here happens to be dopamine, but the transmitter will be released, will go across and bind to this receptor, and the transmitter and the receptor both have a specific three-dimensional shape. It's useful to think of the three-dimensional shape as a good metaphor for it is a lock and a key. So the key is the neurotransmitter. It has a specific shape. It can only fit into a lock that has the complementary shape. The receptor is like the lock, and if the shape is just right, the neurotransmitter can fit into that lock and open the door. In this case, we see both dopamine, the neurotransmitter dopamine with its receptors, and we also see an opiate with the opiate receptor, and you can see the shapes are different. So here is what naltrexone does. It binds to this opiate receptor, so it is the kind of key that has exactly the right three-dimensional shape to fit into that receptor. However, in the case of naltrexone, it doesn't have any effect on that receptor. It just sits there. But when it sits there, the opiate, whether it be an endogenous opiate that's produced by our body or whether it be an opiate-like medication that people or drug that people might take, is blocked from getting to the receptor, so it cannot exert its effect. And here's an image of the human brain. And what you see in blue is our brain reward pathway. And that is primarily mediated by the neurotransmitter dopamine that we just talked about. So when dopamine is released in this brain area called the nucleus accumbens, whether it be an animal or a human, there's a sense of reward or reinforcement. And all substances that humans misuse activate this brain reward system. Opioids cause release of dopamine from the area where the dopamine neurons are, which is the ventral tegmental area. Now you're wondering, how is this all relevant to alcohol? I thought the next talk was on opioids. Well, it will be, but it is relevant to alcohol because it has now been proved that when humans consume alcohol, they, sorry, I'm struggling with my mouse a bit here, but when humans consume alcohol, it actually does well, I can't get the pointer right now. It actually does mobilize endogenous opioids, and we don't really need it for this slide. So this is a brain imaging study, and they can actually image the mu opioid receptors in the brain and which ones have a transmitter bound to them and which don't. And they're looking at this area of the nucleus accumbens, which I mentioned to you is the primary area of brain reward. And they image these people in a pre-alcohol state and in a post-alcohol state after they've been given some alcohol, and they looked at both heavy drinkers and people who were not heavy drinkers. But in either case, after the alcohol, there is less binding sites available on the opioid receptors. The only possible explanation for this is that endogenous opioids have gone and occupied those receptors. So we know for a fact that part of the effect of alcohol comes from mobilization of endogenous opioids. So we can use naltrexone as an antagonist to block that effect. And what it might do, what we believe it does, is it does two things. One, if someone consumes alcohol, it's going to blunt the amount of reinforcement or the high or buzz they get. If that's the reason they're drinking, they're not going to get much benefit from that, and they're going to possibly stop using the alcohol. And also, when people begin to have cravings or think about using alcohol, that's also a time when the endogenous opioids and dopamine can get mobilized, and therefore the naltrexone might help with the cravings. So how well does naltrexone work? So this is also a somewhat complicated study where they looked at and this was really the first study to show that naltrexone was effective for alcohol use disorder. They looked at the combination of naltrexone and coping skills relapse prevention, which is very, very similar, if not identical, to the type of cognitive behavioral therapy for SUD that all of you people practice. They had 97 participants in the study who all had the DSM-3 at that time alcohol dependence, and they were randomly assigned to both a medication condition and a psychotherapy condition, either naltrexone 50 milligrams per day or placebo, and the coping skills CBT type of therapy versus just supportive therapy. One of their outcomes is a full-blown relapse, 5 or more drinks on one occasion for men, 4 or more drinks on one occasion for women. The reason for the difference between genders is that the amount of alcohol in your bloodstream is dependent on total body water, which is closely related to total body weight, and typically men weigh more than women, and also there are some differences in alcohol metabolism between the sexes. So the first result that you're going to see is not going to be music to your ears, but it's important to see this. So the first outcome they were looking at is continuous abstinence, not even a sip of alcohol. And what you can see here, so these are we've got the percent abstaining from any alcohol at all on our y-axis, and the x-axis is 80 days of the study. And what you can see here is the group that did the best was the supportive therapy combined with the naltrexone. And if that's disappointing to you that the coping skills didn't work better, just hold on 1 minute. So then they looked at the rates of relapse, and again, that's 4 or 5 drinks depending on gender, and this was in the full sample of 97. And what you can see here is that what was important was being on the naltrexone. Both of the forms of psychotherapy did equally well. Now, a very important point that's relevant to your work. Among the sample of 58 who were not abstinent, that means they had some alcohol use, so it's a subsample. The group that did the best was the coping skills plus naltrexone. And that makes a lot of sense because part of CBT for SUD is helping people understand the factors that go into a relapse, and make plans to prevent a relapse. So in that situation, the CBT was, combined with the medication, was extremely useful, beneficial, and led to better outcomes. I should also say, I don't have a slide for this, but these researchers did a follow-up study, and they did find a sleeper effect from the CBT compared to the supportive therapy. In other words, 6 months or so after the study was stopped, the people who learned the CBT skills were still applying those skills and were having better outcomes off of medication and no longer receiving psychotherapy than the people in the other condition. So please be encouraged. This is another study that was simpler, just to let you know. Everyone in the study got the CBT, and some people got naltrexone and some people got a placebo. And as you can see, we're looking at the percent without relapse, and the people who got the active medication did a little better over time than those who got the placebo when they were getting CBT. Another reason for encouragement. So for the oral naltrexone, we typically give 50 milligrams a day. Sometimes if people are not responding to 50, we go up to a little bit of a higher dose, like 100 milligrams. But I want to tell you also about the opportunity we have to reduce our concerns about medication adherence. Medication adherence is important throughout medicine. It is very, very frequent that patients do not take their medications the way they are prescribed. And if we all think about our own behavior, if we're on medications, it's easy to forget. Sometimes I find, like, I'm standing there with my pill bottle in my hand and I go, did I just take my pill or did I not take my pill? Well, I can't remember, so I better not take two, so I may end up taking none. Well, we now have a long-acting injectable form of naltrexone that's a once-a-month injection that obviates all these concerns about whether the person got the medication, because if they got their injection, they got the medication. So this was a large multi-site study, over 600 people with alcohol dependence. The behavioral intervention in this case was low intensity, so it wasn't something like CBT. And here are the results. So in this case, they used two different doses of the injection, but you can kind of ignore the 190 milligrams because it only comes as one dose, the 380 milligrams, since it was approved by the FDA about 11 years ago. So all of these participants, we're looking at the median number of heavy drinking days per month. That's 5 or more for a man, 4 or more for a woman. And in this group of study participants, 2/3 of their days were heavy drinking days. Now, a placebo injection is a pretty strong placebo, so even the people on placebo did extremely well. If we could get those results with our patients, we would be thrilled. But you can see those who got the active 380 milligram injection had statistically superior outcomes in terms of reducing heavy drinking down to almost nothing, even compared to the placebo. So that's how well this injection works. And keep that in mind for your patients who might be struggling with taking an oral medication every day. We're going to move on to talking about acamprosate, which you see the chemical formula here. And that's going to lead us to talking about two other neurotransmitter systems, the glutamate system and the GABA system. Now, these work very similarly to what we were talking about when we showed you the neurons earlier. The glutamate system, represented here by GLU, is the major excitatory system in our brain. So when a glutamate binds to neurons, it turns them on, gets them more active. The GABA, or GABA aminobutyric acid system, is a major inhibitory system in our brain. So when GABA binds to neurons, it tells them to turn off and be more quiet. So you can think of this as your brain having an accelerator, which is the glutamate system, and having a brake, which is the GABA system. And most of the time, these should be in equilibrium. Now, alcohol also affects both of these systems. Alcohol makes our excitation or the glutamate system weaker, and it makes the break stronger. And that makes total sense. Sometimes people get a little giddy and overactive if they've had a little bit to drink, but ultimately people tend to get sedated or even pass out or have a blackout. So in the situation of acute ethanol, we have an excess of inhibition. Now, if someone is consuming alcohol on a regular basis, if we had inhibition all the time, the person wouldn't be able to function, and the brain doesn't like that. So the brain undergoes some type of neuroadaptation. We actually don't know the physiological mechanism for that, but we see that when people are constantly consuming alcohol, they appear to be more back in equilibrium. The sort of prototypical situation where you'll see this, if any of you have ever worked in the emergency room, it's not infrequent to see a patient come in with a blood alcohol of 300 or 400 milligrams per deciliter, which would certainly be enough to overdose. I will guarantee it's enough to overdose anyone on this call and possibly even kill people on this call. But these people appear to be alert. They're walking around. They're talking. They can carry on a conversation. They may not remember any of the conversation. That's because they've undergone this neuroadaptation. So what do we do with that patient? We say, well, you have a serious problem. We're going to put you in the hospital. We're going to put you through withdrawal. And during withdrawal, we remove the ethanol, so the balance goes back to more excitation, which is what we see during alcohol withdrawal, and where people may not sleep, they've got a tremor, they're sweating excessively, they're agitated, and we treat that with medication to get them off their alcohol. We may do that for 3 or 4 days, and then we send them out of the hospital. But remember, this situation took years to develop, and it's not going to go back to normal in a few days. So we're sending someone out who's got excess excitation. And you see this in your patients. They have trouble sleeping. They still feel agitated. They're having maybe racing thoughts and maybe cravings for alcohol. So wouldn't it be nice if we had some medications that could put this back into balance, that would make the brake stronger and the accelerator weaker, but wouldn't make people high? And it actually turns out we do have a couple medications like that, and acamprosate is one, and topiramate, that I'll talk about in a few minutes, is the other. So this is a study with acamprosate, and the people were treated for a year. We're looking at total abstinence here. The red is the acamprosate, the yellow is placebo. And you can see that there are more abstinent people in the acamprosate group compared to the placebo group, and this effect persisted for 1 year after the medication was discontinued. And acamprosate, because of its bioavailability and the fact that it's excreted by the liver and not metabolized, excreted by the kidneys and not metabolized by the liver, does need to be given 3 times a day at a dose of 666 milligrams 3 times a day. So that does require a lot of vigilance about adherence. The nice thing about acamprosate, because it is not metabolized by the liver, it's very, very safe to give to people who might have some underlying liver disease. Now I'm going to talk to you about the most complex study that's very relevant to our topic. It's the combined study. And this was a multi-site study with, as you can see, almost 1,400 patients. And it was looking at the combination of psychotherapy and 2 medications. Now, the rationale for the medications was we get certainly some benefit from Naltrexone, which works on the opioid system, and we get some benefit from acamprosate, which works on the GABA and glutamate systems, but we don't get the benefit that we would like, which is to cure everyone. So since these medications work through different mechanisms, might it not make sense to combine them and maybe get double the effect? And then we want to see how these medications relate to psychotherapy. So we're going to look at 2 different types of psychotherapy. One was called the combined behavioral intervention, and that used about, and it was delivered by professional psychotherapists, either master's or doctoral level, who were trained in delivering this intervention. It was 12 to 16 weekly 1-hour sessions. The first 3 sessions were based on motivational interviewing and motivational enhancement, and the next 9 sessions were very much based on typical CBT relapse prevention. There were a few optional sessions to address specific skills after the therapy if people needed it. The medical management is also a behavioral intervention where the prescriber would see the patient first on a weekly basis and then every other week and then every 4 weeks for a session that would last about 15 minutes with assessing the effects of the medication, determining if there were any side effects that needed to be addressed, and strong encouragement to attend self-help groups. So there were 9 cells in the study. There was double placebo with both forms of psychotherapy, naltrexone plus placebo with both forms of psychotherapy, placebo plus acamprosate with both forms of psychotherapy, the 2 combined medications with both forms of psychotherapy, and then there was a no pill condition. So these people didn't even take a placebo, they took no pill, and they got the combined behavioral intervention. The important thing on this slide is really just to look at the number of drinking days, and the number of drinking days was the main outcome here. They weren't focused on heavy drinking. So they, on average, everyone in the study they were drinking 3/4 of their days, and you can see that on average they were drinking about 12.5. So quite a huge quantity of alcohol. So most of those were heavy drinking days. So what were the findings? Interesting and somewhat disappointing. There were no main effects of any intervention. So the acamprosate alone was not better than placebo. The naltrexone alone was not better than placebo. And the combined behavioral intervention, which is the professional psychotherapy, was not better than the medical management, which was delivered by the prescribers. So the one take-home message, and we should look at what the outcomes were too. Now we're looking at % days abstinence, so it's the opposite of the number of drinking days, and so that everyone in the study on average went from consuming alcohol on 3/4 of the days to being abstinent on 3/4 of the days. So basically, if you want to think of it as bad news, the hypotheses of the study were not proven because none of these things had a particular effect, but everyone got a lot better as long as they got some form of treatment. Now, when they looked at, that was the main effects, and when they looked at interactions, so combining the medications was not helpful. Combining acamprosate with the cognitive behavioral intervention was not helpful compared to the using just the medical management, but there was an interaction between naltrexone and the cognitive behavioral intervention, which you can see in the data here. So these are the average number of days abstinent, and if they were not getting the cognitive behavioral intervention, they had a few more days abstinent on average than those getting placebo, which was a statistically significant effect. And this just shows the same thing graphically, which we're going to skip through. A final interesting finding from the study, which I think is relevant to your work, is remember there was a no pill condition. And so that's represented here. It's the psychotherapy intervention with no pills and no medical management. And again, we're looking at the adjusted mean % days abstinence. And what you can see is that if you got the placebo, so you got a pill, even though it was an inactive pill, you actually did better than the people who didn't get a pill at all. So we aren't going to be prescribing placebos, but we do have the medications we've talked about that can be used, and I think this is encouragement for you to for any of your patients who are struggling at least a bit, to encourage them to try medication. So we're going to just finish up here quickly by talking about a couple of the other medications. Again, topiramate is not FDA approved. Similarly to acamprosate, it works on the GABA and the glutamate systems, adjusting the brain's accelerator and brake. And we're looking at percent heavy drinking days here with the topiramate in black compared to placebo in white over study weeks. And you can see the benefit of the topiramate in reducing heavy drinking. I do want to draw your attention to a couple things. It takes about 5 weeks with this to get up to a therapeutic dose, which is not true of the other medications. The therapeutic doses can be started almost immediately. And also, there was a higher dropout rate in the topiramate group compared to the placebo. And topiramate does seem to have, we'll talk more about this, well, actually we won't be talking more about this next time, but I'll mention it now. So we will, topiramate does seem to have some effect on cognitive function, particularly word finding difficulties, and some patients find that difficult to tolerate. But it's definitely a medication to consider because it is effective if your patient does not respond to the other medications. A side benefit of topiramate is it actually causes weight loss in some people. Finally, we're going to mention gabapentin, which also works on the braking system, the GABA system, by making it stronger and getting back to that balance. It's a complicated looking slide, but we're looking at in this study, there were placebo, gabapentin 900 milligrams per day, and gabapentin 1800 milligrams per day, the mean number of drinks per week, and this dark area is the gabapentin, which you can see is beating placebo. This is the 1800 milligrams of gabapentin, and even the 900 milligrams does a bit better than placebo early in the study. So that is definitely an option for people who cannot take any of the other medications, and also gabapentin is a useful medication for people who have chronic neuropathic pain. So and that's not uncommon in people with alcohol use disorder, so it might be a strong consideration in those particular patients. So I am going to conclude by mentioning the obvious, which is that behavioral interventions like CBT-SUD are absolutely essential for the treatment of alcohol use disorder. So thank you all for the good work that you're doing with our patients using that intervention. I believe all patients with alcohol use disorder should be offered medications, especially if they're not doing as well as desired with the CBT alone. And I think we all agreed at the beginning, given its efficacy, the fact that there's an injectable form, and the fact that it has a pretty good safety profile, naltrexone in most cases is the first medication to try. So I'm going to stop there, and we're going to see how many questions we can answer in the next few minutes.
Thank you so much, Dr. Saxon. For those of you who have questions, please put them in the chat box. This is really helpful and really shows how we can work together effectively, those of us who are not prescribing providers, with the prescribing providers, to provide the best and most optimal evidence-based treatment.
So I'm looking at the chat box and I don't see any questions, except for when is the next training, which is 4 weeks from today. So if I didn't annoy you all today, come back in 4 weeks. Okay, what evidence is there for topiramate for cocaine abstinence? So I appreciate that question. There is at least one well-done, double-blind, randomized controlled trial that showed that topiramate was better than placebo for cocaine use disorder. So that's a great question because I showed near the beginning that disulfiram can be helpful for cocaine use disorder, and topiramate can as well. So for patients who have co-occurring alcohol use disorder and cocaine use disorder, I typically would recommend disulfiram as our first choice of medication, but if the patient can't take disulfiram, say because the patient can't achieve 2 days of abstinence, I think topiramate would be a very good choice in that situation. Understanding that to get up to a therapeutic dose could take 3 to 5 weeks. Okay, do you use handout education when you start naltrexone for alcohol use disorder? I personally don't use that because I explain it to the patients in my session, but I think the VA does have very good materials about that. If we don't have them already, they're in the process of being developed through the pharmacy service academic detailing, so there should be very good handouts available. I can't tell you right now exactly how to direct you to where they are, but we will marshal our resources and get that information out. So the next question is there a generic for naltrexone? And naltrexone is the generic name, so the oral medication brand name is Revia, and the brand name for the injection is Vivitrol. So the oral is off patent, so it really is a generic medication. The injectable still is on patent, so it has that brand name Vivitrol, and that's the only formulation that it comes in. Next question, what are the contraindications to naltrexone? Really, the only absolute contraindication is being on, and we'll talk more about this next month with the opioids, but currently taking opioid analgesic medications or currently using illicit street opioids. Because it's an antagonist at the opioid receptor, if someone has opioids in their system, they will get what we call precipitated withdrawal or instant opioid withdrawal if they're given naltrexone. So if you have a patient with alcohol use disorder and chronic pain who might be on opioids, which is not what we would recommend, but we still do have some patients in our system who fall into that category, naltrexone is not the medication you'll be using with them. You'd be using disulfiram, acamprosate, topiramate, gabapentin, etc. Okay. Okay, so I'm loose. Okay. Oh, well, I might have missed some of the questions, but here's one. Clients are resistant to 3 times a day dose for acamprosate. What do you think about 3 tablets twice a day? I think acamprosate is working for them. I think that would be okay. I also work with the patients on their medication adherence, so I try and develop a little ritual out of it. And what I recommend to them is you're going to plan 3 specific times that you're going to take your medication. One is going to be when you first get up in the morning. One is going to be sometime around noontime, and one is going to be right before you go to bed at night. And I want you to take 5 minutes out of your day. I want you to say the serenity prayer to yourself, and I want you to think about the reasons why you're in recovery and why you're trying to make your life better, and then take your medication. So I think those little rituals can help. But I think if 3 times a day is not possible, let's go for the twice a day. Let's see. I've heard of severe withdrawal side effects from a client who missed their injectable and now will not go back on it. Naltrexone thoughts. There certainly shouldn't be. There's no evidence of withdrawal or side effects from people missing their naltrexone, especially if we're talking about someone who's taking it for alcohol use disorder. But every patient is different, and if that happened with this one patient, I'm not necessarily discounting it, and obviously naltrexone is not going to be a good medication for that particular patient, so I would look at using one of the other medications. So next question, what are the side effects of naltrexone? Very good point. I didn't go into side effects in depth just for lack of time, but this is important because most of the side effects are nuisance side effects, and they're self-limited and usually go away, but they can, at the outset of treatment, cause patients to want to stop the medication. And with naltrexone, primarily it has to do with the GI system. So nausea or GI upset can be very prominent. Nausea is a condition that is very, very aversive to humans, and if you have a little bit of nausea, you will do anything to get rid of that. And almost always, people who have nausea the first few days on naltrexone, that does get better and go away. So I try and coach patients through that. You certainly can, well, most of you who are psychotherapists can't do this, but I can. Other prescribers can prescribe an antiemetic for a few days, and we have some very effective antiemetics like ondansetron, or just encourage people, if they're taking the oral, to take it with food in their stomach, and that sort of thing. And usually it goes away. Other potential side effects are headaches, dizziness, and it can have a variable effect on sleep. It can, for some people, it can make them more drowsy, and for some people, it can cause some insomnia. And again, most of those get better, so you have to coach them through it. It tends to be a little bit easier with the injectable because you get a little bit of a blip in blood level the first day or two with the injectable, then you get a very steady, moderate level in the bloodstream that doesn't cause many side effects. And so if they get nausea after their first injection, it's going to go away in a day or two, and when they come back for their next injection 4 weeks later, it's very unlikely they will remember that or even be concerned about it. But you do have to coach them and manage the side effects. And there are some people for whom the nausea is so bad they just can't tolerate it, and then we need to look at a different medication. Let's see. Have you found any particular time of day best for naltrexone? So if it's going to be, that would be the oral medication. So I think people do best. I certainly do best if I take my medications either first thing in the morning or right before bedtime. So either way with the patient, and you can, for some people, the effects on sleep are going to be neutral, but if they're having some sedation from the naltrexone, then obviously bedtime is the best time, and if they're having some insomnia from the naltrexone, then obviously morning time is the best time. So I think just individualize that with the patient, and again, a lot of coaching about having a plan for taking medication and adherence. Next question, what about depression around time of injection? I recently had a veteran who reported depression, which he noticed after his first injection. So it is the case that people can get a dysphoric response. I don't think there's any very good evidence that naltrexone is related to a serious medication-induced depression in most people, especially with alcohol use disorder. It might be a little more, possibly occur in people with opioid use disorder, although there again it's very rare. So with this person who got some depressed mood or depressive symptoms around the time of the injection, I would see how the person did in the later weeks while the injection's still active. I would probably go for a second injection and see if those symptoms occurred again. And if they continue to occur and the patient finds that really bothersome, then I think, again, that's probably indication for a switch in medication. So the next question is one that Ananda, okay. So the next question, there's one for Ananda there that I would answer. What would be the recommended treatment modality you would recommend in treating someone who has bipolar, heavy alcohol consumption, and cocaine usage? A very complicated, difficult patient who unfortunately is all too frequent among the population we deal with. Well, so I think we don't have really good evidence about do you try and deal with this sequentially and stabilize one disorder and then the other? So I think you probably want to go for all three. Obviously, you want to get the first effort is going to be to get the patient on a mood stabilizer to manage the bipolar if they're in a manic episode. And even if they're in a depressive episode, you want to get them on a mood stabilizer. And then, of course, there's controversy in the field about whether someone who's got bipolar depression should or should not be on an antidepressant. But I think the latest evidence would indicate that it's not particularly dangerous for most patients to be started on an antidepressant. Then work with them on your CBT for the alcohol, and probably I would treat that the way I would treat any other alcohol use disorder, which would be to go, if there's no contraindications, Naltrexone as the first line treatment. I would be thinking very strongly about using the injectable form in a bipolar patient who's likely to have issues with medication adherence. And then for the cocaine, then I would probably not use medication for the cocaine directly, immediately, and see if getting the bipolar disorder and maybe the alcohol use under control. And of course, you're trying to treat the cocaine with your CBT. And then if the cocaine use persists, then I would think about a switch of medication, either to disulfiram or acamprosate. And these are patients that we've all had, and you've got to work with them for a long time, and there's ups and downs, and they embarrass you by showing up in the ER at midnight despite all your good work. So all I can say is I'm with you there, and keep treating these patients, because sometimes we do have some success with them.
Okay, thank you again, Dr. Saxon, for your excellent presentation, and thank you everyone else for participating in today's session. Before we close, I want to remind you about next month. Dr. Saxon will be back, and he'll be presenting medication-assisted treatment for opioids in conjunction with CBT-SUD. And Ananda just put in the registration link for anyone who forgot to register. There are CEUs for today's presentation.